Good afternoon, everybody. Thank you very much, everyone, for joining. I'm sure that more people will join as we work through. As I was saying to Dr. Guerrero-Ramos and Dr. Angulo, then, having invested time and effort and money in clinical trials for the last 5 years, 10 years, finally the data is coming to maturity for combat. So we have already seen the data from the Dutch group on BCG failures. Today we will talk about the large set of data from the Spanish group. We should shortly see a head-to-head with BCG full paper from one of our presenters today, Felix, hello, which fingers crossed will be accepted shortly. And then we should see the long-awaited publication of HIVEC E, large multi-center prospective randomized trial in Spain in intermediate risk. And hopefully, shortly into the new year, we will see the BCG failure data from the full HIVEC E registry. But what we'll talk about today, very kindly, Felix and Javier have offered to join us as two of the key authors from the HIVEC E Spain paper that was accepted around 2 or 3 weeks ago, to talk us through not only their findings from the paper, which Felix will go through first, but also some of the next steps and the thoughts of the Spanish group on how intravesical treatment, intravesical chemohypothermia, HIVEC, will continue and grow from here. So we will continue to be joined. I'm letting people in all the time from the waiting room. Some names I know, some stories to tell. But Felix, if I pass over to you, if you take the screen, then you should be able to start your presentation.
Thank you very much for the kind invitation. It's a pleasure for me to be here. As you know, I've been working with combat and HIVEC since the very beginning, since the first BCG shortages. We were some of the first in Spain starting to use this technology, and I really believe in it. And we've had good results, and it has helped us quite a lot, especially in those times of some BCG shortages. I'm going to present the part. I'm going to do like a summary of the paper we published and some of the conclusions we could extract from this paper. So here's, let me see. These are my disclosures, and these are some relevant remarks for the paper. This is included in the article. The funding of this research was by Combat Medical, the owner of the devices we use for HIVEC. This paper I'm going to present had an ethics committee approval, and every patient who was included in the study signed an informed consent. So this is the remarks we have to do before, and this is the agenda of what we are going to talk about. I'll start speaking about the background and the methods of this study. Then we will analyze efficacy outcomes. Then we will analyze safety outcomes. And finally, I will sum up the discussion, and I will do some final remarks with some questions we could make after reading the paper. So if we start with the background of bladder cancer, we know that non-muscle invasive bladder cancer has 2 key features, which are recurrence and progression. And this is what has the highest burden in our clinic, with the follow-up and all the treatments which are whose objective is to decrease the possibility of recurrence and progression. These are the two key things we have, which is mitomycin or epirubicin or doxorubicin, but the most common and the most popular is mitomycin or BCG. But we know that in spite of this, we have many patients. We have some patients who will recur or progress, and also this, as I was talking with Guy, this looks like a British supermarket, but these are the shortages of certain substances like BCG or even mitomycin that we have recently had. So what we want is, with this paper, is to present the real world results of HIVEC with mitomycin C using the recirculant combat BRS device. And these data come from a prospective observational trial that we did in Spain, the Spanish group, the Spanish experience that way HIVEC from Spain. So with this, we aim to assess efficacy and safety, and also identify, if possible, the optimal schedule that should assist for future and bigger trials. Because as you know, not even with normothermic chemotherapy, we have a defined schedule. We do have it for BCG with the SWOG trials, but not for chemotherapy, intravesical chemotherapy. So this, for those of you who do not know how this works, this is the combat BRS. This is easy to use and this is portable. And you use a three-way catheter, and the mitomycin comes diluted into the bladder and recirculates and comes out, and through this aluminum interchanger, it gets heated until 42 degrees centigrade. So we present here the results of a prospective observational multi-center study of 9 hospitals in Spain with data from 2012 to 2020. The last update of the database was in June 2021, this year, and these are the data that are presented in the paper. These are patients with non-muscle invasive bladder cancer who underwent TURBT, a transurethral resection of the bladder tumor, followed by mitomycin with this device, with HIVEC, combat BRS, and there are also other modalities of treatment, and we'll see the populations. In the trial, we have in our database, in the Spanish database, we have 628 patients, but for the study, we defined 2 populations. One of them is the safety population, which will be used for the safety analysis, as we will see later. And these are those patients who received at least 1 instillation with HIVEC with mitomycin. The full analysis set population is that population which we used to assess efficacy. And these are all those patients who received adjuvant therapy with mitomycin. Some of them is neoadjuvant, so those were excluded for the efficacy analysis. And also those patients have information on cancer risk at diagnosis and follow-up information that lets us assess the efficacy status. So the endpoints are in relation with the different populations defined for the study. For the efficacy assessment, as I told you, those patients who have the adjuvant treatment with the follow-up data and the information on cancer status, and the efficacy assessment was, as we couldn't do it other way, being this one type of cancer with recurrence, progression-free survival, and overall survival. The prognostic factors for recurrence, progression, and overall survival in the multivariate analysis was also calculated in the full analysis set population. And the safety was assessed in the SAF population, which is those any patient included in the database who received at least 1 instillation of HIVEC mitomycin. It doesn't matter if pre or post-op or adjuvant or whatever. So in our the population in our database, as you can see, half of the tumors are single, half are multiple. Most, like 2/3 of the tumor are smaller than 3 centimeters, and 1/3 of the patients have big tumors. We have more TA than T1 tumors, and looking at the grade, there's a uniform distribution with grade 1, 2, and 3. If we look at the EAU risk stratification, this is based on the EAU 2020 and former guidelines. As you know, this year it's quite different. We have that 60% of the patients included in this trial, in this study, are intermediate risk, and 40% are high-risk patients. Some of the patients were previously treated with different substances, and the median follow-up is around 2 years, which is good to calculate recurrence and progression. So we will start with the efficacy outcomes in this paper. We are starting to analyze recurrence-free survival. For this, as I told you, this was the full analysis set population, which is 500 patients. And you can see that globally, for this population, we have a 2-year recurrence-free survival of 71%. This survival is increased for intermediate risk compared to high risk, as expected. And here you can see the curve for the whole population and the curve for high risk and intermediate risk patients, which obviously have a better recurrence-free survival. If we look at the factors that show statistical significance in the multivariate analysis for recurrence-free survival, we see that especially those patients who received more than 4 months of treatment or with maintenance have better outcomes and better response to the treatment. So this is important, and we will highlight this later. With respect to progression-free survival, as you remember, there's this mixture of 60% intermediate, 40% high-risk patients. We have a two-year progression-free survival of 92% and 5 years of 90%. This is even better for intermediate risk, but very good numbers also for high-risk patients. Again, you can see here that there are differences, obviously, between high and intermediate risk patients. And again, looking at the multivariate analysis and looking at the predictors for progression in our multivariate analysis, again, we find that those patients with more treatment and maintenance have better outcomes, and this is statistically significant. Then looking at overall survival, well, I'll just show you the curves. Overall survival seems a little bit worse also for high-risk patients, and just in 2 years, we cannot assess really cancer-specific overall survival, but we see that those older patients, and again, those treatments under 4 months are predictors of a worse survival of these patients. Also in these 500 people who were the full analysis set population. If we look at the safety outcomes, we see that here we analyze the safety population, which are those patients who received at least 1 instillation of HIVEC of mitomycin C with HIVEC. And the number, if we had 500 for the full analysis set, now this number increases until almost 600 patients. And we had that 1/3 of the patient had at least 1 adverse event. Here you can see the severity of the adverse events. In gray, you can see those patients who did not experience any adverse event. Those patients with mild adverse events in blue, which are grade 1, and a small proportion of patients with grade 3, grade 4 adverse events. The most frequent adverse events experienced by our patients in our study were dysuria, bladder pain, and urgency. As you can see, all these symptoms, all the other symptoms which have a variable incidence are frequent with any of the other instillations we can use for the bladder, such as BCG, normothermic chemotherapy with mitomycin, doxorubicin, or whatever. Analyzing these data and having them in context with respect to the previous literature, we can see that if we do an indirect comparison with chemohyperthermia with radiofrequency, it looks that these real-world data have better efficacy outcomes, but we cannot compare trials between trials, so we cannot compare. It's not directly comparable, but it looks like these that are better. It looks like we have a similar progression-free survival than if we use BCG with a maintenance regimen. As we know, BCG has a sense and is better than normothermic chemo if we use maintenance, not just induction. So in this case, it looks like our data provide a similar progression-free survival as the standard BCG maintenance schedules. I highlighted previously those different curves with statistical significance and significance in the multivariate analysis that maintenance and treatments longer than 4 months provide better results, and this also happens and is consistent with the results presented for radio frequency. There are some previous HIVEC reports. We also had this at the European and the American Urology Congress, and safety looks similar to the previous reports and consistent with other reports. And tolerability in this aspect of safety, tolerability looks better than radio frequency chemohyperthermia, especially due to the lesions that sometimes radio frequency causes inside the bladder mucosa. Two strengths to highlight for the trial. This is a prospective study and a consecutive inclusion of every patient treated with HIVEC mitomycin C in the centers that participated in the registry. The limitations are obviously that there's not a control arm, as this was not a randomized study, but an observational prospective study, and there are different schedules between the centers. But this limitation about different schedules has led us to identify that longer treatment schedules provide better results. The conclusions of the study, and this I just did a picture of the article, is that HIVEC with mitomycin C with combat BRS bladder recirculation system is efficacious and well tolerated for those patients with intermediate and high risk non-muscle invasive bladder cancer. As we said before, and I want to highlight it again, a maintenance schedule should be recommended, as we have demonstrated that treatments more than 4 months are the most important independent prognostic factors. And it also looks like HIVEC in primary and intermediate risk tumors offers better treatment results. So there are some partially answered questions, and there's another question which is rising after seeing this data. About the optimal schedule, we could partially answer that it looks that at least we need 4 months and a maintenance schedule. Regarding efficacy for primary versus recurrent tumor, we have seen that it looks like it's better for primary. Regarding the performance in CIS, no CIS patients were included in this registry, but from previous registries, previous trial, it looks like performance in CIS could be poorer than in pure papillary tumors. Regarding the BCG and responsive scenario, as Guy was commenting before, some data were recently published in Neurologic Oncology with positive results. More data will be coming. And regarding randomized trials, we have, well, HIVEC 1 and HIVEC 2, I think they will have results soon. And we have HIVEC HR, which is the trial we designed in our center, and will soon, I hope, be published. It's under peer review. And this is a randomized trial just in high-risk patients with papillary tumors and no CIS. We need further investigation, of course, but if we go back again, and this is one of the last slides, if we go back again to the union multivariate analysis, we can see, I didn't show this because this was just to summarize, I showed the multivariate analysis, but in the univariate analysis for the, if we analyze tumor recurrence, we see that in our series using chemohyperthermia, the multiplicity and the size of the tumor are not prognostic factors, and it also happens for progression. Multiple versus single, or size more or less than 3 centimeters are not prognostic factors. So this is one of the questions that we have known from many years ago, that tumor size and multiplicity are risk factors for progression and recurrence. And I would ask myself, and maybe you can do the same question, if could HIVEC beat them as prognostic factors due to the better penetration of the drug through the bladder wall? This is a question we were commenting on the other day, and this could be one of the questions that arise from this study and could need and would be worth to have further investigation with the respect. And this is all for this. As you know, you can download the article. It's open access. Any questions, please, you can do them on the chat. And now Dr. Angulo will speak to us about other things related to our registry. Thank you very much for your attention.
Thank you, Felix. If anybody has any urgent questions that they would like to throw into the chat now, then we can deal with them. But I'm sure that some of the things that we're thinking will probably be dealt with by Dr. Angulo in his follow-up speech. So we will see perhaps at the end, but feel free to add your questions to the chat as we go through, and we'll have a discussion at the end of the presentation.
Hello, friends. Well, after Felix' wonderful speak, there is not much left to say, but I would like to think on a presentation, a shorter presentation on also the strengths and limitations that Felix already talked about, and also the future possibilities of HIVEC Epidemiology Spain. Because this enormous work done, it must not end with this publication. This is a publication of the general results, but of course, the population is this, also presented by Felix, but we have very interesting aspects, like regarding different subpopulations that could be increased in the future, and maybe that we could furtherly research on them, especially for the different heterogeneous type of maintenance, because some of these patients receive induction 6 weeks, followed by monthly maintenance. Others follow only induction, and some patients follow directly induction without maintenance, starting with the old regime, 1 year regime, 1 month every installation for 12 months. So we have differences, also heterogeneity in the maintenance group, and also different duration, because the duration and the maintenance seems to be the same factor, the same prognostic factor, but in fact it is not. In this paper, we understood and we proved that the number of installations, that is the number of months under treatment, is a factor for recurrence. But the real factor for progression is not the months, the number of months. It's the fact that the patient was under a strategy of maintenance. So, of course, maintenance leads to higher number of installations, but you can start maintenance and interrupt, or you can start maintenance and continue for 2 years. So this is the problem presented in the guidelines, especially for the intermediate risk group, in which the lack of definition of the correct maintenance schedule, I mean time, duration, and other questions that could be raised, is to be defined yet. Also, in this population, we have patients with previous BCG, so they are unresponsive to BCG. Not all of them, but most of them are unresponsive. So that could be also an excellent sub-analysis. And we also have, well, this data has been presented by Felix. That means that the combat registry, we started this 6 years ago, but you have seen 80 years data. That was because some authors like Alejandro Sousa had a previous experience that was also included in the registry. When Silvia Martinez started this in Spain, he chose me because I was participating in the HIVEC-1 trial. I was one of the investigators in the HIVEC-1 trial, and we designed this database. So that is the reason because of which it was presented for approval in my hospital. However, as I was fully devoted to inclusion in HIVEC-1, I did not include patients in this prospective database. But now, some years later, 6 years later, it comes back to me for analysis, working with the CRO, with Pertica, with the statisticians, and doing the medical writing of the article we have shared today. So the results are impressive because this is real world data, and real world data is very variable, but we have an excellent recurrence-free survival rate, and especially a much more than excellent progression-free rate. If you stratify for the intermediate and for the high risk, you also see the numbers are still impressive when compared to the classical alternatives presented in the guidelines, which is long-term BCG or long-term cold mitomycin. Also, regarding tolerance, Felix presented the data very nicely, but I have to stress the fact that 70% of the patients suffer no adverse events, no toxicity. So the tolerance in 70% of the patient was excellent. And only 3%, 2.7% suffer serious toxicity. The most frequent adverse effects have also already been presented: dysuria, bladder pain, urgency. They are minor, skin rash, but this is not for the device, for the deliverance route. It's for the drug itself. So the question of the tolerance, I think it's already very well covered by the multiple articles that have been presented in the last 2 years, and this is a large number of patients that confirms the same idea that HIVEC mitomycin is very safe. So the monthly adjunct mitomycin maintenance also has proved with this article that the recurrence and especially the progression rate is much better than weekly induction regime. And this brings us to a very interesting point, because when we started to use HIVEC mitomycin, it was just let's do substitute BCG in terms of shortage. So we did at least six. So at least 6 is not enough. At least 6 is not enough, and we can see it clearly with this data. This is what Felix has already shown. I think it's the most important conclusion. But if we stratify, this is not in the paper, this is a point beyond. If we stratify the maintenance, the red maintenance is the monthly maintenance without induction. And the green one is the monthly maintenance with induction. So we see that for recurrence, both maintenance regimes protect recurrence. However, for progression, only the induction plus long-term maintenance really protects progression, because the monthly 1 year, so that's the mean number of administrations was 9, so 9 plus standard error is the 1 year full schedule. So what does it mean? Maintenance, you can also do different maintenance. So maintenance should be studied in depth in our data. Strengths of the HIVEC epidemiology is this, showing that maintenance is important. And the prospective nature of the study, as Felix said, the consecutive inclusion of patients reduces the inherent risk of a study like this, but the selection bias and the information bias and the reporting of side effects is reduced and brings some uniformity both in the chemotherapy dosage and the technique of distillation with this recirculating system. The limitations are also important. So Felix also said that the lack of control is a limitation. It is not a limitation, it is a very serious limitation. However, we try to turn it around. We use the data we have, which is the treatment, and we compare different treatment, different schedules, different times, and we got conclusions. So we got results and we got conclusions. Imagine if in a study like this, if at that time, we did not, because it was not possible. So shortages, patients without no treatment are also included, or patients with BCG are included, or patients with temperature room mitomycin are included. That would be a tremendous important data derived from that, but we don't have it. So this, we have to wait for the results for the prospective trials, the high risk, which is also coming, and the HIVEC 1, possibly in the future, the HIVEC 2. As I said, the variation in the maintenance scheme and treatment duration is inherent to the heterogeneous population, and this is a limitation, but as Felix said also, we turn the limitation into a strength with the conclusions derived. The disease-specific mortality needs better definition. That's true. I mean, if you realize we use the overall mortality, and we could not use at this moment the disease-specific mortality, because I have to admit that in this protocol, the HIVEC epidemiology, we lack the definition of a mortality group. If we have a mortality group, we could have really defined the mortality cause. Some people die with a progression of the bladder cancer, but also with a breast cancer or also with a lung cancer. So it's very difficult to assign if the ultimate cause of death was really the bladder cancer or the other cancer of the patient. You can understand this limitation exists in all registries, but for us it was much. We thought it was much correct to speak about overall mortality. And if you realize, we saw the duration of treatment is a prognostic risk factor for overall mortality. However, of course, together with age of the patient, together of the age, so that means it could be a natural conclusion. So I wouldn't say that more months of treatment with HIVEC mitomycin preserves some mortality. So this is the natural, because you know the patients that receive longer treatment are those that are doing better, because they are in a better shape, in a better form, in a better natural organicity of their bodies. So that means that conclusion, which is very brilliant and nice, should be taken with care. And so, you know, the limitations are not few. The success of bladder sparing strategies in the specific populations also need further research, and that is where we are centering. We are centering in the data of analyzing specific subpopulations. We have already studied to analyze the maintenance without induction, as I have already shown you, and we are getting very nice conclusions on that for a secondary publication. And we probably in the future, if the number of patients with a neoadjuvant 80 milligrams HIVEC mitomycin could do another different subset following Alejandro initial description of patients. And also the adjuvant HIVEC in combination with BCG is a very, very interesting subgroup of the analysis that hopefully we could continue in the future. Now, besides from this, we also have two interesting next coming papers. One is the progression in the BCG unresponsive scenario, which is, as you said, is being analyzed in the full set of HIVEC patients in the world. But we are concluding the bladder sparing strategies in these patients, and revising the database and trying to also have information, because we have 51 patients, which is a good numbers in this registry. And also another question is, what happens with the very high risk patients? Does HIVEC help? How much does it help in preserving and sparing the bladder of these patients? So this is these are the patients we are going to analyze further, and this will be future evaluations for the HIVEC E. Hopefully we can write new papers in the future. The conclusions is coincident with what Felix said. HIVEC E is an excellent source of real-world HIVEC data. Thank you, Silvia Martinez, for initiating this and for your constant support. And thank you for the patients who gave the consent for inclusion. And thank you for all the physicians involved in long-term maintenance of the registry, which is the most important key of success for a study like this. We will try to continue under investigation the several interesting aspects I already mentioned, and probably more that will come to our mind in the future. And that's all. Thank you very much.
Wonderful. Thank you very much, Dr. Angulo. Thank you, Felix, for illuminating talks and giving us a little bit more understanding than just reading from the paper and the conclusions of the paper. If anyone has any questions, if they'd like to add them into the chat, I'll start us off. If you read the EAU guidelines for chemotherapy dosing, just normal intravasical treatments of chemotherapy, all it says is that the regime, the number of doses and their timings is much debated. Surely we can come to a better consensus on what that should be for intermediate risk patients, for high risk patients, for very high risk patients. What are your thoughts? What this says that we should be doing more. Should we go to 3 years like we used to with a SWOG protocol? What, if I'll ask Javier first, what are your thoughts? What should we be doing?
Sorry, with the very high risk.
Well, let us start from the worst cases, then with the very high risk patients. What dose schedule, what regimen would you give the patients? 6 + 9, 3 years use? What would you advise?
I would try to use full maintenance. If the patient is well, I would try to use very long-term maintenance. I'll go for the 2 years, regime. If the patient is really a very high risk group, he needs induction and he needs maintenance. And that maintenance typically is performed with BCG, that's the LAM protocol for 2 or even 3 years. And if we use HIVEC mitomycin, I'll go in the same route. So I choose to continue, if possible, for at least 2 years.
Okay. Felix, do you have any, let's move down to high risk and intermediate risk patients. What have you found from the treatments that you've done, both in this and in the HIVEC HR paper?
Well, at the very beginning, when we started using HIVEC, we used 6 weekly plus 6 monthly instillations with HIVEC for every patient, both intermediate and high risk patients. And after we had the mitomycin shortages and speaking with some other colleagues that also use HIVEC, I saw that they were using 4 weekly plus 3 monthly instillations in intermediate risk. So since then, when we had this mitomycin shortage, and from then I've been continuing with this schedule. And in my center, we use 4 + 3 in intermediate risk, 6 + 6 in high risk. With the previous results we have published in the congresses of HIVEC HR, I won't speak about the definite one, the definite results. I don't want to do spoilers.
Not yet.
I want everybody to read the paper. So the preliminary data we presented in Chicago and last year virtually, and this with 6 + 6. There was no clear difference between BCG and HIVEC for high-risk patients, which is a very good news and a very good new data, okay? And I don't know if maybe for those at highest risk, as Javier says, and that definition in VA guidelines, whose primary treatment should be cystectomy, really, and I know that most of us do not perform cystectomies on these patients. We try to give a chance to intravesical therapies, but maybe for those at the highest risk, I would try to go for longer schedules if I used HIVEC.
Wonderful, thank you. I mean, that seems to be, having discussed this paper around the world, and to some extent at the Global Bladder Cancer meeting in Ghent a month ago. It does seem to be the commonly held belief that at least 1 year's worth of maintenance looks like, especially for the intermediate, high, and very high risk patients, that maintenance is the most important independent prognostic factor in seeing that differential between the lines on the Kaplan-Meier curve. Lovely. We have a couple of questions coming in. Come on, people, throw me some more. We were discussing this beforehand, actually. What about single post-operative doses of chemotherapy? Do you use those in your practice? Javier?
Yes, I use it in every case in which I don't have a positive cytology or I can anticipate is a high risk group. So I do not use it in high risk. I use it in low and intermediate.
Hot or cold?
Now we're using both, but more we're using cold.
Excellent. Good answer. Thank you. On behalf of our shareholders, good answer. Felix, what about in your practice?
Same indications as Javier said, those intermediate and low risk patients, no positive cytology, no previous high grade tumor or CIS, and cold. In every patient we use cold due to the logistics in our center. we should do some changes, and well, not the majority of the patients, I mean, all those recurrences after high grades and all that won't go for HIVEC, so for postoperative dose. So now we're using it cold.
You're saying you want me to give you another machine so that it's easier for you to do it hot in after? Okay, fine. We'll discuss this after the meeting, as they say in this sort of.
It's portable. It's easy to use. I mean, it's not like other big machines, so it's very easy to use.
Yes, we hope so. We have a number of people joining at the last minute. Goodness me. A question from the floor, and actually a very pertinent one. We have a gentleman with us who has himself been treated by HIVEC. You know, those of us who work at Combat will be accused of commercializing the subject, and perhaps those of us in academic papers of intellectualizing the subject. But we have a patient here with us who has been on the end of the catheter, so has great experience there. And David is asking, does the international community liaise on HIVEC? How much is it talked about? I mean, from Combat's point of view, we have a clinical advisory board where it's discussed, disappointingly, virtually only for the last couple of years, but generally in and around the meetings that that we have around the world for the European and American meetings. But I have seen it change in the 6 or 7 years that I've been here, from a concept that had to be explained from first principles to the urologists to something that is now commonly understood, perhaps not as commonly used as our shareholders would like, but commonly understood and seen as a useful alternative, at least a useful alternative in cases where primary therapy has failed. What's happening in Spain? Are you guys getting together and discussing this at the Cueto meetings? How is it discussed?
Yes, in our case, with the HIVEC HR trial, this was organized and this was an investigator-initiated trial in our center, but all our results have been updated in the Cueto group. As you know, the Cueto is the Spanish urothelial carcinoma collaborative working group. And we have been presenting all the updates of our results in the Cueto. And we discuss usually in the Cueto about new trials and new proposals with HIVEC, as well as with other things, stratifying patients in other ways. But HIVEC is one of the usual topics we have there for the design of new trials.
Yes, thank you. So for David, thank you for your question, but you can trust us that it is now being discussed much more internationally than previously, and that we have international groups collaborating on existing and future trials. One of the trials that is coming up in Spain will be using gemcitabine. We said earlier that we have had a mitomycin shortage, and we've had a BCG shortage. I think, you know, other than having an electricity shortage, which there's a lot of South African friends on here I see, so other than load sharing and having an electricity shortage, what else can we run out of? But what about in the times of mitomycin shortage? What other drugs have you used? Do you think could be used? What are your thoughts in this area? Javier?
I don't have a good answer to that.
Have you used gemcitabine? Have you used epirubicin? Have you used doxorubicin?
Very exceptionally. No.
I can see some names on the participant list from areas where mitomycin is not routinely available. And this can be an issue. Sometimes it's only available in the 2 milligram dose that the ophthalmic surgeons use. And if you ask your pharmacist to make you up 40 milligrams from 2 milligram vials, they will never talk to you again. But Felix, have you used any other drugs?
I have a normothermic perfusion, not with hyperthermia, because in our center we kept all the mitomycin just for hyperthermia. So we continued with our HIVEC treatments with mitomycin, and patients under normothermia underwent treatment with either epirubicin or gemcitabine. Gemcitabine was shortly used because we, at the beginning, we had a normal and usual gemcitabine, but then gemcitabine started coming in an alcohol solution that, of course, was not tolerated by the patients, and we switched it to epirubicin.
Anecdotally, at least, I mean, we have 2 papers published on epirubicin, relatively small cohorts, one from Italy and one from somewhere else, I'm not sure. Anecdotally saying that it has similar clinical effects and a similarly improved clinical effect in hypothermic use rather than normothermic use. We have scientific data, some published and some on file, from in vitro work and some animal work that shows that the delta between hot and cold in terms of the amount of drug absorbed is greatest and by far greatest in gemcitabine, or gemcitabine. Sorry, it's a lot of Spaniards on the call. Does this mean that because more of it is absorbed in a pig's bladder, that it will have a higher efficacy than hot mitomycin in a human bladder? We don't know, but the answer in medicine is always we don't know, but watch this space, and that will probably be the next study that we're looking at in Spain. Do we have any further questions from anyone in the room? Lovely. We're just getting towards an hour, so that's worked about right. There's a lot of my friends from around the world on the distribution side I can see on here. So if I share briefly a couple of things that we have coming from this meeting, we will share with all of you one of our simple diagrams showing the results in a way that you can explain to a doctor when you only have a few minutes of their time. This will also come with some sales guidance as well, and we should be in a position to release this tomorrow. And we spoke briefly of BCG failure and CIS. I'll just remind you that this paper was published in September of this year from the Dutch group with some involvement from Hugh Mosterford in the UK, who sits on the EAU guidelines of a 70% CIS patient group of BCG failures, and showing excellent recurrence-free survival at 6 months. We discussed a little bit real-world evidence, and the most cynical may consider registry data to be real-world evidence. The FDA are now very interested in real-world evidence for the most difficult patient groups, for the BCG failures and for the very high-risk patients, because this is what's happening every day out there in the real world. Any more for any more? Last knockings. I don't see any more questions, so lovely. Thank you very much. Hang on, Mr. Bruce White, I can see has appeared in his car. There you go, Ed. I best let the boss have a chat.
I'd just like to thank Felix Angulo for the presentation. It's fantastic. Thank you very much, and thanks for your support. And just to add, in terms of our ongoing endeavours in terms of the clinical work, one of the outcomes that we need to do more work, we will be launching, and you will see very, very shortly, BCG unresponsive trial in both CIS plus and minus papillary and papillary. There'll be a 200 patient trial that will be based out of the UK, and that will hopefully show the results that we've had, and that will be starting in early next year. And as we've already mentioned, we're going to be running initially a neoadjunctive gemcitabine trial, which will also look at the pharmacology and the marker analysis, which will then lead into a larger phase 3 trial. If the gemcitabine has succeeded, we will include gemcitabine neoadjunctive trial against standard of care in we're fully committed in terms of running a large clinical program. That's our plans for 2022 at least, as well as continuing to update the registry, and to thank everybody who commits time to the registry, because it really is key, because the results that are coming from this are now helping us to guide and get a better understanding how to improve the treatment in terms of certainly maintenance, which wasn't clear before. So now hopefully that means that we can improve clinical outcomes. So thank you very much for everybody's support.
Lovely. So thank you all. There will be a recording of this available, which we will host on our YouTube channel. And for the commercial guys on here, I will send out probably tomorrow the cheat sheet on the outputs, the clinical outputs that has come from it. So once again, Felix, thank you very much. Dr. Angulo, thank you very much. And we will be back soon with the HIVEC high risk paper. So before Christmas, we should say, we'll have a guest. So thank you very much each, and good afternoon.
Thank you.